I want to welcome you all. My name is Christopher Kunseri. I am joining you from Milwaukee, Wisconsin. It's 8:05 a.m. Central Time here. And again, I like to always acknowledge the brains behind this collaboration, Dr. Ibrahim Osimbawale and his crew, and the crew from FMC, the Federal Medical Center in Abuja. And again, we are presenting another cutting edge information on sickle cell. We have experts around, international, global experts. We also have the pleasure of Dr. Scott Emakwo here as a moderator. In my mind and in my world, is the best we can have as a moderator and as an intellectual on a topic of this nature. So I am grateful to you, Dr. Scott, for accepting to serve as a moderator. However, I think this collaborative experience have actually helped all of us to really be able to develop cutting edge science or be able to work together collaboratively to provide the best quality care to our patients back home in Nigeria. So without taking too much time any longer, I want to, allow Dr. Scott to continue with the moderation, and thanks all to the speakers and to all those on the forum, waiting anxiously to listen to information on sickle cell. Thank you very much, Dr. Scott.
Mr. President, I thank you, sir. If the Chief Medical Director of the Federal Medical Center is available, Professor Ahmed, we'd like to hear from him. And if he's not available, anybody from the Federal Medical Center can also give an opening remark. Where we have Dr. Adebayo, I think is from the Federal Medical Center. And if he's available and he would like to give a remark on behalf of the Chief Medical Director, we'll be glad to hear him. Dr. Adebayo.
Okay, thank you very much, Professor Ajofe. I am Dr. Biok Muftau. I'm the moderator from Abuja, and Prof is unavoidably absent right now. He's attending hyper delegation meeting in the ministry or the presidency, as I'm told. Yes, but he is in full support of this program as usual, and he has given us go ahead to do the presentation, and also to appreciate our partners from the American end. So he thanks everybody for keeping faith with this program, and the hospital is benefiting greatly from the wealth of knowledge shared through the program. We appreciate the effort of the AMPA presidents and the presenters from America. So without wasting time, I have his directive to thank everybody once again, and wish us a very succinct and successful discussion and deliberation. Thank you very much.
Thank you very much, Dr. Bioku. I appreciate you standing in for the Chief Medical Director. Just for housekeeping, I would like to appreciate everybody who is logged into this virtual program. If you are not speaking, we will appreciate it if you just mute yourself so that we do not have the kind of echo and the disturbance that we just experienced a moment ago. It is now my pleasure to introduce, no, not my pleasure. I would like Dr. Bioku to introduce Dr. Adebayo, who is going to make the presentations for the cases that we are going to hear today. Dr. Bioku, I pass it over back to you.
Okay, thank you, Prof. The presentation from Abuja end is going to commence with a case presentation of a typical case of sickle cell disease patients that was managed here. So that will immediately follow with Dr. Adebayo's presentation. Just before his presentation, I will introduce him. Well, let me quickly call on Dr. Ewu, a medical officer from Department of Hematology and Blood Transfusion, Federal Medical Center, Abuja, so to present the case presentation. Dr. Ewu, if you are there, you can start. You have 7 minutes to do your presentation, maximum.
Good day, all. I am Dr. Endalin Iwu, a medical officer in the Department of Hematology and Blood Transfusion, Federal Medical Center, Abuja. I present Ms. M.O., a 31-year-old female marketer in a microfinance bank. She's single. She presented with left shoulder and left hip pain of 2 days duration. She was in her usual state of health 2 days prior to presentation when she developed left-sided shoulder and hip pain, which were gradual in onset and worsened over time. There was no associated trauma. Pain score was 10/10. There was associated fever, which was moderate grade and continuous, no vomiting or diarrhea. There was no neck pain, stiffness or headache, no urinary symptoms. There was no history of passage of dark-colored urine. Patient was recently treated for malaria with a negative post-therapy test. A known hemoglobin SS and peptic ulcer disease patient. She was not regular with clinic visit and have not had her prescribed immunization for sickle cell disease patients, but her routine medication were vitamin B complex, folic acid, and Palodril. She's not a non-hypertensive, diabetic, or asthmatic. There was no history of stroke. She had cesarean section 4 years ago. She had been transfused 5 times in the past, each in different occasions. She was not sure of her steady state packed cell volume at the time of presentation. The frequency of her pain crisis was recently weekly, but it used to be once per year. She's the first of 6 offspring and the only hemoglobin SS in her family. Both parents are hemoglobin AS. Father and siblings are alive and well. Mother died recently with chronic liver disease. She's an occasional alcohol user and have not used tobacco in the past. Patient is a single mother with financial constraints. She attended MENAC at the age of 17. Last menstrual period was 9 days prior to presentation. She has 2 to 3 days flow in a 28-day regular cycle. Review of system, nothing was contributory. A young woman in obvious painful distress, febrile with temperature of 38.1 degrees Celsius, significantly pale and etheric, acylous, mildly dehydrated, no palpable peripheral lymph node, no pedal edema. Her pulse rate was 114 beats per minute. BP was 122/84 millimeters of mercury. Her sounds 1 and 2 were heard. Her respiratory rate was 27 cycles per minute. SpO2 was 90% in room air. There was no crepitations. There was epigastric and right hypochondral tenderness with palpable hepatomegaly. There was moderate tenderness at the left shoulder and hip joint. There was no differential warmth. Central nervous system was essentially normal. Provisional diagnosis was hemoglobin SS with vaso-occlusive crisis, secondary to sepsis, and acute exacerbation of peptic ulcer disease. Presenting full blood count showed PCV of 17.9%, 17.95%. Platelet was 117,000 per microliter. White blood cell count was 15,800 380 per microliter with granulocytosis. Peripheral blood film showed toxic granulation in neutrophil sickle cells, target cells, nucleated red cells, and neutrophil hypersegmentation. Renal function tests and urinalysis were normal. Malaria parasite test was negative. Blood culture did not yield any growth, and she was not able to do liver function tests due to financial constraints. Ceftriaxone and meropenem were serially administered without resolution of fever. Piperacillin tazobactam combined with gentamicin permanently stopped the fever within 24 hours of commencement. Normal saline was alternated with 5% dextrose water, 1 liter 12 hourly. IV omeprazole 40 milligram 12 hourly was given. Intranasal oxygen 4 liter per minute was given. She was transfused with 2 units of red blood cells, each unit per day, and her pain was controlled with intravenous pentazocine, oral morphine, dihydrocodeine, and tramadol. The analgesics were alternated according to the severity of her pain. Other medications that were given were folic acid, vitamin B complex, then artemisinin-based anti-malaria was given after blood transfusion as per protocol in our center. She was commenced on warfarin 3 milligram daily when it was noticed she was not ambulant for 2 days due to localized swelling and pain on the right shin. Patient, however, started passing dark colored urine 2 days after the last blood transfusion. Red cell antibody screening test was positive. Antibody identification test could not be done. IV fluid was stopped and patient was encouraged to take Libra oral fluid. Post-transfusion PCV showed 10.9% as against 17.95% of presenting PCV. Additional diagnosis of delayed hemolytic transfusion reaction was made, and patient was placed on subcutaneous erythropoietin 4,000 international units 3 times weekly for 2 weeks. Patient PCV began to rise 2 days after commencement of subcutaneous erythropoietin. On the 6th day, the PCV was 17.98%. She was discharged on the 13th day of admission on oral medication, cefpodoxime, folic acid, vitamin B complex, palodril, and dihydrocodeine. 5 days after discharge, PCV rose to 20.55%. Patient was canceled on hydroxyurea and encouraged to start her routine vaccination. I have presented a 31-year-old female hemoglobin SS patient who presented with left hip and shoulder pain and was managed for vaso-occlusive crisis secondary to sepsis and exacerbation of peptic ulcer disease with delayed hemolytic transfusion reaction. Thank you.
Thank you very much, Dr. Iwu, for keeping to time. And before we call on the lead presenter from the Department of Hematology, I want to inform us that Dr. Olufemi Adebayo, the current HOD of Department of Hematology and Blood Transfusion, Federal Medical Center, Abuja, he graduated from the Obafemi University, Ile-Ife, and proceeded to do his postgraduate training on laboratory medicine. He's a fellow of West African College of Physicians, laboratory medicine currently. Dr. Adebayo, if we are ready, you can start your presentation because of time.
Okay. Good day, all. I'm Dr. Adebayo Olufemi. consultant hematologist at the Federal Medical Center, Abuja. I'm meant to discuss the management of the patient that Dr. Endaliniwu just presented to us. The patient, a 31-year-old female with hemoglobin SS, had 3 diagnoses, as Dr. Iwu said. The diagnosis of vaso-occlusive crisis, peptic ulcer disease, and delayed hemolytic transfusion reaction. I'm going to go through all these one after the other. First, vaso-occlusive crisis is said to be the commonest presentation of the events seen in hemoglobin in sickle cell disease patients. And the first manifestation that is observed in infancy is called hand-foot syndrome, in which there's vaso-occlusion of the hand and the feet, and it will result in swelling of the hand, small bones of the hand and the feet. The major cause, or the real cause of this in sickle cell disease patient is because of vaso-occlusion of small vessels, and this of course will lead to hypoxia, which in turn will lead to ischemic injury, which then will lead to infarction of the bone marrow and the cortex as well. This will now cause stimulation of nociceptic neurons, and the patient begins to feel pain. Talking about manifestation, talking about the principle of management of vaso-occlusive crisis in sickle cell disease patients. Number one, we need to identify the cause or the trigger of this crisis. Then we also need to treat it. If you don't treat the trigger, then the problem persists. And the trigger can be infection. In most of the times with our patients here, many of them will have infection, either malaria infection in this part of the world or bacterial infection. Apart from infection, they can also have stress. Stress can be the trigger, whether physical stress, physical exertion, or emotional stress. Then apart from this, exposure to extremes of temperature, like when it is too cold, they can have vasoconstriction. When it is too hot, they can sweat excessively and get dehydrated. Then apart from this, any form of cause of dehydration too can lead to it. It's also been observed that these patients who take alcohol or who smoke cigarettes also have increased frequency of vaso-occlusive crisis. Then apart from this, it's also been observed that pregnancy and menstruation can also lead to vaso-occlusive crisis, because VOC is observed to be increased in this subset of people, or females, when they are menstruating and they have hemoglobin, they are sickle cell disease patients. I've talked about the okay. So apart from identifying and treating the precipitating factors, we also need to dehydrate patient very well. And okay, let me go back to what we did for this patient. I meant to talk about all these factors in relation to the patient. So treating, identifying the precipitating factors in the patient presented by Dr. Iwu, we noticed that patient was running fever, and we eventually saw evidence of sepsis. This patient was running moderate grade, later high grade, continuous fever. We noticed that it was continuous. In contrast to if it were to be malaria fever, many times malaria fever will present with intermittent fever. So patient was having continuous fever. Then that was why we placed the patient on antibiotics. And next thing we did was to effect rehydration. We could not go all out to give 3 liters per day that we usually do because of the reduced hemoglobin in this patient. We didn't want to cause hemodilution that would further make the patient deteriorate. So we gave 1 liter 12 hourly, amounting to 2 liters per day, but we encourage that to continue to take water orally to augment what we were giving intravenously. Then analgesia. Analgesia is a very important factor in combating vaso-occlusive crisis in these patients. And usually we we try to assess their pain severity by way of numerical pain score assessment. We ask them to try to assess the severity from a scale of 1 to 10. And many times they are able to give us an idea of what they are feeling. So analgesia will be based on this. If the pain score is considered to be mild, we give mild analgesia. In fact, ordinary, don't let me say ordinary, non-steroidal analgesic agent like paracetamol can be combined with non-opioid analgesic agent like paracetamol, sorry for that, can be combined with non-steroidal anti-inflammatory drugs like diclofenac, like ibuprofen, in a case of mild VOC. If it is moderate, we may have to combine opioids to all these ones I've mentioned. And if it is severe, in fact, opioids should be there and parenteral opioids should be instituted. There are two ways to go about this. Continuous analgesia with giving the control of the dosing to the patient. That's patient-controlled analgesia is recognized. But in this part of the world, we usually use intermittent analgesia, paused analgesia. That was what we did for the patient Dr. Iwu presented. And the next thing is blood transfusion. The issue of blood transfusion is such that it is not, we need to consider certain things. For example, if the patient's VOC is proving to be difficult to control, and we look at the peripheral blood film, we are seeing very high irreversibly sickled red cells, we may need to give exchange blood transfusion to break this pain of VOC. And if the PCV or hemoglobin is too low, like we saw in this index case, we may need to give simple transfusion. And unfortunately, the simple transfusion we gave resulted in one of the complications of transfusion, that is delayed hemolytic blood transfusion reaction. Then apart from the issue of blood transfusion, patient needs to rest very well for all these drugs to be able to work well. Then, so we admitted the patient so that the patient could rest. Then there are other secondary level of prevention of vaso-occlusive crisis, like counseling the patient about usual triggers, like I mentioned, and the ways by which the patient can prevent or avoid these triggers. Then pharmacological interventions like hydroxyurea, and more recently some new novel drugs like crizanlizumab, like voxelotor. I believe that Prof is going to dish out more of this to us. Then routine vaccinations too, because like I said before, infection is one of the commonest causes of VOC. So we advise them to go for routine vaccinations against most of these encapsulated organisms that are implicated in causing vaso-occlusive crisis. Next one, peptic ulcer disease. We noticed that patients had abused NSAIDs in the past, and she also tested previously before the index admission for Helicobacter pylori. And PUD, the patient had been treated sometimes before the index admission for peptic ulcer disease using triple regimen. Then treatment was, we used proton pump inhibitor, that's omeprazole, because we, like I said, she had been treated earlier with triple regimen. The third one, delayed hemolytic transfusion reaction. What happens in delayed hemolytic blood transfusion reaction is such that there's a mismatch between red cell antigens of the patient and that of the donor. And usually there must have been a time of sensitization of the immune system for delayed hemolytic transfusion reaction to really occur. So with our thinking was that the previous 5 units of blood that this patient had received in the past one or more units of those must have included some irregular red cell antigens that the patient lacked. And this will have stimulated or sensitized the immune system of this patient. So, and what we saw during treatment management of this patient was that after giving her 2 units of blood, instead of the hemoglobin level to rise post-transfusion, it went down drastically and severely. So, and we, the way we go about it is usually we send for allo antibody, red cell allo antibody screening tests, which we did for this patient, and it returned positive. However, we could not do antibody identification test because that should be the next step. After the screening test comes positive, then we are meant to do antibody identification tests, which will show us either one or more than one implicated red cell antigen. And the simple way to go about it is subsequent transfusion. With subsequent transfusion, we should choose a donor that lacks the implicated antigen, that is antigen negative. But in this case, because we could not identify the antigen in the first place, we could not identify it, so we were a little helpless. That was why we resorted to other ways of managing this complication of transfusion. And that was why we used erythropoietin. And luckily for us, PCV was able to rise beyond our expectation. I should say at this point that this is the second case that we observed in which erythropoietin will result in very rapid rate of increase in hemoglobin. We don't experience that in some other or many other patients that we have treated with indication for erythropoietin use. In summary, the patient was a 31-year-old non-female hemoglobin SS patient who presented with features of vaso-occlusive crisis secondary to sepsis. She also had exacerbated peptic ulcer disease and severe delayed hemolytic transfusion reaction. She was managed essentially with antibiotics, with rehydration, with analgesia, and also we had to use prophylactic anticoagulant because patient was non-ambulant for days because of pain. Then we also used proton pump inhibitor to combat the peptic ulcer disease, and also we used erythropoietin because of the severe hemolysis that she had. And she was discharged after 13 days, like Dr. Iwu said, on admission, when she became very stable, and she remained stable during post-discharge visit, clinic visits. These are my references. Thank you very much for listening.
Thank you very much. Before I hand over to Emeritus Professor Ajovi to continue from United States end, I want to appeal to the participants to please start dropping their comments and questions on the chat room so that they can be attended to at the end of the presentation. Thank you very much. Prof.
Well, thank you very much, Dr. Bioku and Dr. Debayo. I'm not sure whether this case is open for discussion or whether we just wait until after the lecture before we discuss it. I would like to defer to Dr. Bioku and Adebayo and also to our lecturer.
I think we're going to wait till after the second presentation, Prof.
All right, so we wait till after the second presentation. All right, good. Thank you very much. First to Dr. Iwu, and then to Dr. Adebayo, who summarized the case and gave a more detailed presentation of the reasons why the things were done with this patient. Now it's my pleasure to introduce to you the lecturer. It is always very easy to introduce somebody who is your favorite, who you like very much. So it is easy for me to introduce this young woman. who I always lay claim to. Dr. Sunkwo is a professor of medicine and pediatrics at Atrium Health and the director of Sickle Cell Disease Enterprise at Levin Cancer Institute in Charlotte, North Carolina. This young lady has nearly 30 years of clinical and research experience in sickle cell disease. That's how much she has devoted her career to the study of this single disease. She earned her medical degree from the University of Nigeria, and then she came to the United States and earned a master's degree in public health from the prestigious Johns Hopkins University in Baltimore, Maryland. She did a pediatric residency training at the University of Medicine and Dentistry in New Jersey, in Newark, New Jersey, and then followed that with a fellowship training in pediatric hematology, oncology, and bone marrow transplantation at Columbia University in New York. These are all very high-powered institutions in the United States. She then finally joined the faculty at Emory University in Atlanta and became a very consequential consultant to the Georgia Department of Public Health in sickle cell disease, publishing a guidebook on the care of patients with this disease for that department. She moved from Atlanta and moved to North Carolina, where she has risen to become a professor at the Levin Cancer Institute in Charlotte, North Carolina. Almost 10 years ago, she founded the Sickle Cell Disease Enterprise at Levin Cancer Institute and Atrium Health, using a decentralized care delivery framework to establish care for sickle cell disease patients across the Carolinas. A review of this program, which I have seen in several publications, has shown that it has been a very successful program in improving the quality of life of persons living with sickle cell disease, while at the same time reducing healthcare costs for these patients, length of stay in the hospital, readmission frequency, and mortality. This also is combined with the remarkable gains in patient engagement by this program. One of the greatest problems we face, those of us who take care of children with sickle cell disease, one of the greatest problems we face is the transition of these patients from pediatrics to adult care. Dr. Sunkwo has been a spirited advocate for this transition process, and she has led the establishment of a national model for pediatric to adult care transition, leveraging peer mentorship and community engagement for this purpose. She continues to be active in research. She's currently a principal investigator in a multi-center study comparing the effectiveness of adding virtual peer mentoring to a structured education-based transition program for emerging adults with sickle cell disease. This program, this study, has been massively funded by the nonprofit organization Patient Outcomes Research Institute, PCORI, to the tune of nearly $10 million, which is what she's operating for her research. I said I claim this young woman, and the reason I claim her is that I call her a worry girl coming from my hometown. And she is that feisty, she is that spunky, and she is a phenomenal advocate for sickle cell disease. We are going to listen to her today. And for all of you who are interested in sickle cell disease in Nigeria, please, at the end of this, try to get a contact, and she's always available to give virtual consultations and to also advise on strategies for managing these patients. It is my pleasure to call on Dr. Ifeinwa Osunkwo to deliver her lecture.
Thank you so much, Prof. Oh my God, you're about to make me cry. Thank you, sir. Thank you so much. And it's an honor to be introduced by you. So I grew up watching you and learning from you. And so this is kind of like coming full circle. So thank you so much. And thank you to everybody on the call, the team at FMC. You guys did a phenomenal job with this patient. I know that there was a lot of anxiety around, will she make it or will she not make it? And she survived, and that's kudos to the excellent clinical care that you provided. So my task today is within 30 minutes to 40 minutes to kind of go over sickle cell disease and touch on the current trends in management. And I just want to make sure that, Natisha, my slides, can everybody see my slides?
No, I don't see your slides yet.
Not yet.
Okay, let me see.
Okay, sorry, Dr. Adebayo wants to share his slide so that you can share your slide now.
Okay, thank you.
Yes, yes. Have you done that? Okay, you can try sharing your slide down now.
Okay, let me try. Okay.
Okay.
You can see it now?
Coming
Yeah,
up slowly. I think it's coming up.
Loading.
Yeah.
Loading. Yeah.
Okay, perfect. So these are my disclosures. And our goal today is to review and understand.
We're seeing the wrong.
You want to do slide view?
Share a different screen.
Okay, let's see, stop sharing.
No, I think they are coming out okay, Letitia. It's just that there were
Okay.
two slides to the same in the.
Okay, I think I got it now. How's that?
Yeah, good.
Perfect.
Perfect. All right, thank you so much, guys. So our goal today is to understand the genetics and pathophysiology of sickle cell disease. We will review the common general acute and chronic complications and spend some time on the standard treatment of sickle cell disease. And I will defer to my Nigerian colleagues on what is standard in Nigeria. I'm coming from an American context, but really the overall idea of disease management should be the same. The supportive care will have some nuances based on geography. And we will discuss at the end, during the Q&A, the role of public-private partnerships in how we optimize sickle cell outcomes in low and middle income countries. So sickle cell disease is a disease of hemoglobin quantity and quality. You produce fewer amounts of hemoglobin and the quality is not normal. So the cells look like bananas, they're stiff, and they break apart much faster than a regular red blood cell. A typical red blood cell lives for 3 to 4 months. A sickle red blood cell lives for 2 to 3 weeks. And the reason is there's a genetic deficiency in the beta globin gene that causes a mutation of your hemoglobin to become a hemoglobin S red blood cell. There are several different types of sickle cell disease. And this is important because when I was in medical school, there was a lot of public health misunderstanding of what sickle cell was and what was sickle cell trait. You have to inherit 2 abnormal copies of the beta globin gene, one of which has to be hemoglobin S to have sickle cell disease. If you inherit 2 abnormal copies and one of them produces hemoglobin A, that hemoglobin will be less than 50% of your total amount of hemoglobin. So in sickle cell disease, you have more hemoglobin S than any other hemoglobin that you produce. And there are over 7 different species of sickle cell disease genotypes. Of note, the most common is hemoglobin SS. Hemoglobin SC is the second most common in most countries, and it's very common in Nigeria and West Africa. Hemoglobin SC used to be referred to as sickle cell trait, and SS as sickle cell disease. I just want to make sure that we take away from today's talk that SC is not sickle cell trait. SC means you have 2 abnormal hemoglobins. One is hemoglobin S and one is hemoglobin C. The hemoglobin C red blood cell is microcytic, so small, and it's prone to dehydration, and it breaks apart a lot faster than a regular hemoglobin molecule, hemoglobin A. The term mild or less severe disease in sickle cell disease descriptions is relative. And I have seen people with hemoglobin SS. I have a patient who just passed away last week who was 80 years old with SS. I have seen hemoglobin SC patients who pass away in their under the age of 10. So disease severity is quite relative. And I listed here the different types of sickle cell disease that are most common: SS, SC, S beta plus thalassemia, S beta 0 thalassemia. You have things like SD, SE, and SO ARA. Hemoglobin S beta thalassemia is where you have hemoglobin S molecule and a beta thalassemia mutation in the second hemoglobin molecule. And the beta globin gene can produce a little bit of red blood cells that have hemoglobin A or no normal red blood cells. This is a autosomal recessive disease. And it's really important that as you see a sickle cell patient, that you educate them on how this disease is transmitted to their children. Two parents with sickle cell traits have a 25% chance of having a child with sickle cell disease for every pregnancy. It's not if you have 4 kids, you have 1 out of 4 sickle cell children. When I was in medical school, I had a friend of mine whose cousins, there were 7 children and 6 of them had sickle cell disease in the family. So you can have more than 1 sickle cell child if both parents are the traits. We did a survey of sickle cell disease patients and providers around the world. We looked at 6 geographical regions and we surveyed 2,100 patients for 16 countries. And what we found was that about 40% of sickle cell patients around the world are under the age of 18. So there's a very high prevalence of early mortality. They don't live to their 3rd and 4th decade. In countries like the US and Europe, the average of the median age is 29 years of age. In countries like Nigeria and Ghana and other countries in Africa, the median age of sickle cell disease is 17 years. It's important to remember that about 80% of the world's population of sickle cell disease occurs in sub-Saharan Africa. So this is a very relevant case to discuss in this presentation. And I have numbers for you here. In Nigeria, almost 100,000 babies are born with sickle cell disease every single year. In the continent of Africa, 60% of sickle cell disease is comprised in 3 countries: Nigeria, Democratic Republic of Congo, and Tanzania. So we have a huge burden of sickle cell disease in our country. And it begs us to pay attention to this because the challenge is the majority of these children will die before their 5th birthday. Sickle cell disease is the most common genetic disorder in the US and of course in other countries. This slide talks about the US prevalence of lifespan rate of 45 to 48. I wish that in my country, the average sickle cell person will live to be 45 to 48 years of age. They have multi-organ failure over time in addition to the acute problems, and there's a life of prolonged pain and lifelong suffering. Sickle cell is more common than many, many other genetic diseases, but unfortunately around the world, very few people understand or know or remember that this disease is very prevalent. The very simple way of describing sickle cell disease to a patient is you have cells that are abnormally shaped, and as they flow in your bloodstream, they block your blood flow and cause damage to your organs, acute damage and chronic damage. But we have a better understanding of the complex pathophysiology of sickle cell disease. It starts with hemoglobin polymerization in the bloodstream. The provider who talks this morning talked about dehydration, infection, pregnancy, stress, change in temperature, too hot, too cold. These are things that trigger hemoglobin polymerization, and then that makes the red blood cell sickle. And once the cell is sickled, it is prone to hemolysis, which means the cell breaks up and releases the internal blood contents into the plasma. Now, when this happens, the internal contents of a red blood cell is toxic to your blood vessel lining and to other blood cells. And it causes something called sterile inflammation. When you have this inflammation, it causes your blood vessel lining to get activated. It causes your blood cells, your white blood cells, your platelets, and your red blood cells to get activated. They become very sticky and they stick together to each other and to the blood vessel lining. It's not just the red cells that clump. The red cells cause clumping of the red cells, the white cells, and the platelets, and they stick to each other and to the blood vessel lining, causing vaso-occlusion, which is what leads to all the downstream issues of sickle cell disease. This very simple cartoon can put it to you in a little bit more of a graphic. Red blood cells sickle, they hemolyze, and they cause anemia, so the PCV drops. But in addition to that, the hemolysis causes inflammation and cell activation. Cells begin to adhere together and also to the blood vessel lining. There is damage to the blood vessel lining that causes a vasculopathy, and then you have vaso-occlusion and vaso-occlusive crisis. You've seen this in your clinic. A young child comes in with a very big belly, and you feel a large spleen and a large liver. They have pain, and you see swelling on their hands and their feet. This can lead to osteomyelitis and bone infarcts in the fingers. Their eyes are very yellow. They have bossing of the skull. They have overbite of their jaw, and they don't thrive. They're small for age. The patient we discussed this morning had delayed puberty. She had menarche at age 17. Most children have menarche at age 13. So they have delayed puberty, and they have multiple other complications. They're underweight, they have joint damage, etc. But in the US, sickle cell doesn't look like that. It looks like this little baby who's robust and chubby, or my friend who's 65 years old with hemoglobin SS today, or this baby, or a PhD student from at one of the major universities who has sickle cell disease and just had a baby. It is a multi-system disorder. Everywhere that blood flows in the body can be damaged by sickle cell disease. And I tell my patients that think about diabetes. You have high blood sugar in your blood, and anywhere your blood flows, you can get damage from diabetes. It's the same thing with sickle cell disease. Every organ can be affected, but in addition, you also have pain. You can have acute problems, pain crisis, acute chest syndrome, acute stroke, priapism, acute spleen and liver sequestration, bone infarct. You can also have chronic problems like chronic lung disease, congestive heart failure, cognitive deficiencies, retinopathy or damage to your eye. You can have gallstones, you can have avascular necrosis of your joints, you can have leg ulcers, and of course, you can have chronic pain. But also typical medical problems like ulcers, like H. pylori, like high blood pressure and diabetes are much more severe in this setting of sickle cell disease. There's some things we don't think about very much in sickle cell disease that I just want to highlight. Depression, anxiety, post-traumatic stress disorder. This is what makes patients refuse to come into healthcare because they're trying to avoid confronting their medical issues. Erectile dysfunction for the men, pregnancy complications. There's a very high risk of maternal mortality and infant mortality in a pregnant woman. Blood clots, and then of course, early mortality. One of my colleagues in Abuja talked about the different triggers. I'm not going to hash this to death, but again, alcohol, pregnancy, physical and psychological stress, low oxygen and other medical problems, as well as dehydration. We have benefited in the US from many, many decades of research and clinical care improvement. In 1972, the Sickle Cell Act was passed in the US. And subsequent to that, we began universal newborn screening, penicillin prophylaxis, hydroxyurea, and transfusion therapy. This all led to the improved lifespan. In Nigeria, unfortunately, we still don't have universal newborn screening. We don't have universal access to hydroxyurea, and we definitely don't have universal access to transfusions and even penicillin prophylaxis. By the time you know the child has sickle cell disease, they may be halfway down the grade. And so it's critical that we think about how do we begin to mimic what we've seen in other countries to improve the outcomes of sickle cell patients. Pain in sickle cell disease is the main reason why they come to healthcare. We did a survey, and what we found was that in Nigeria and Ghana, the average patient had about 3 pain episodes a year. In America and Europe and other high-income countries, they had about 4 pain crises a year. Now, before you get very excited, there's a reason for this. And that's in the slide below. The average lifespan or age of the sickle cell patient in Ghana was 17 years of age, and the average age of the person in America and in Europe was about 30 years of age. If you live longer, you live long enough to get the more complications from sickle cell disease. And so it's not that reassuring that in Africa and in Nigeria and Ghana, our patients don't live as long. We also found that the proportion of patients in Ghana and Nigeria are not having a good access to treatments to protect themselves from their disease. And so if you look at the slide here, green is Nigeria and Ghana. And for transfusions, pain medication, IV fluids, and clinical trials and new drugs, we have lower access than many other patients in different countries. We also find that there's a lot of emotional and cognitive burden in sickle cell disease, and people in Africa report that they really want to have access to emotional support to manage the challenges that they have with their sickle cell disease. Overall provider access, about 53% of providers are specialized in Africa and about 44% are non-specialized. But in terms of the number of people available to treat sickle cell patients, we have a significant deficiency in sub-Saharan Africa. You all know this, and I think it was mentioned in the case, there is no blood test that will tell you that a patient is having a sickle cell crisis. You go by clinical judgment and exclude other reasons for pain. So what are the main acute complications of sickle cell disease? This is a picture of stroke. You can have hemorrhagic stroke or ischemic stroke. It happens pretty early as 6 to 9 months of age, and about 11% of sickle cell patients will have a stroke before their 21st birthday. As they get older, they have a risk of silent strokes, and that gets to a range of 40% by the age of 40. And this is a reason for early death, and reason for poor learning, a reason for having difficulty walking, and really having a morbid quality of life. Acute chest syndrome is probably one of the scariest sickle cell complications because it can lead to mortality in over 50% of patients. They present with a new pulmonary infiltrate on X-ray with chest pain, with or without respiratory distress, coughing, wheezing, rales, with or without fever, with or without hypoxia. Interestingly enough, you may bring them into the hospital for pain crisis on day 1, and they only develop this after 2 to 3 days of being in the hospital for a typical pain crisis. Joint damage is very, very common. I remember in medical school, one of my friends had sickle cell disease, and he walked with a limp because he had avascular necrosis of both of his hips. He also had it in his shoulder and in his knees. It is a very, very difficult complication because at an early age, you may need to have a hip replacement. But it can also affect any joint in the body. They get a lot of chronic pain in their knees and their back. It's called arthritis. They have compression spine deformities in their back where the vertebrae begin to crumble because the bones, you have sickling inside the bones of the back. Retinopathy is probably not very well recognized in sub-Saharan Africa. They don't have vision problems until they go blind. You have to proactively screen them for sickle cell retinopathy, just like you do for diabetes. The difference between diabetes and sickle cell disease is that diabetes retinopathy is more central. Sickle cell retinopathy is more peripheral. So you got to look at the outskirts of the eye, in the back of the eye, versus right around the fovea in the middle of the eye. Leg ulcers are extremely common in sub-Saharan Africa. When we did our medical mission a couple of years ago, well, the first patient we saw, he came all the way from Enugu to Abuja because of a recalcitrant leg ulcer. And of course, the dactylitis or the hand-foot syndrome. Spleen sequestration crisis, infarcts, liver sequestration crisis is very, very common in sickle cell disease. Pulmonary hypertension, where your blood vessels get thickened in the heart and the lungs, and there's a differential pressure gradient between the heart and the lungs. It has a 45% mortality in 3 years. This is a picture of a spleen that was removed from a sickle cell patient. It can get as big as a 9-month-old baby, and it's a cause of severe anemia and anemic heart failure. My very first patient in medical school, in the A&E, the mother came and said, "Doctor, help me with my child." He put the baby in my arms, the baby looked at me and then died. And it was from a spleen sequestration episode triggered by malaria that caused severe anemia. Her hemoglobin was 1, so a PCV of about 5. Liver sequestration, we talked about that, and liver cirrhosis from sickling and fibrosis, but also a complication of recurrent transfusion therapy to treat the acute complications of sickle cell disease. I want to spend some time on this complication because sickle cell patients can make gallstones because they have a red cell turnover that is elevated. It is one of the most under-recognized complications in adults with sickle cell disease. They typically do not present with your traditional triad of fever, jaundice, and right upper quadrant pain that you see in the non-sickle cell patient. They may present with pain crisis repeatedly, every week, every 2 weeks. And the reason is their gallstones is not acute, it's a chronic preceding cholecystitis. And so they may have a mildly elevated white count, but really no other stigmata. They may not report right upper quadrant pain. They may say their pain is in their back or their shoulder or their left side. And when you do the cholecystectomy, you see fibrosis and shriveling and chronic inflammation of the gallbladder and multiple stones. And I would recommend that for this particular patient that we talked about today, we should look for chronic cholecystitis as the reason why she keeps coming back for pain crisis on a regular basis and a trigger for the hemolysis that she's in. Dental decay is very common, partly because of the dry mouth from the opioids, but also because of pain, jaw infarcts, and poor dental hygiene from people who are sick a lot. Constipation, constipation, constipation. During our medical mission in 2019, every patient I saw with sickle cell disease had belly pain, back pain, and when you ask them, they poop once or 3 times a week. Constipation is a big problem in sickle cell disease. It may be from the opioids or the pain medication. It may be from chronic dehydration. It may be from reduced blood flow to the intestines and dysmotility of the gut. It may be from the NSAIDs. It may be from H. pylori, but constipation is an easy thing to treat. You got to drink a lot of water, take a lot of fiber, and manage your constipation. So how do we treat sickle cell disease? Well, we know that the pathophysiology is complex, and the treatment needs to address hemostasis activation and vascular inflammation. And you want to make sure you target the different pathways that trigger the sickle cell disease complications, from the venous thromboembolism pathway, to the inflammation pathway, to the pulmonary hypertension pathway, to the chronic end organ damage pathway. So this is the roadmap that we use in the US. And we are blessed because we have good healthcare access. We have medicine, we have all these new drugs. We have the primary care doctors, the specialists, we have acute care doctors, we have emergency room, and we have 911. When you don't have those things, you have to do the best you can with what you have, and that is okay. Because in sickle cell disease, even just seeing them on a regular schedule and giving them education does a lot to improve their life expectancy, even without any additional medication. Giving them their vitamins, vitamin D, folic acid, vitamin B12, giving them their treatment for malaria and worm infestation can go a long way to treating the disease. But in sickle cell disease, the perfect or the utopia is to manage the disease, treat their emotional complications, treat their pain, treat their organ complications, and provide psychosocial support and community support to help them with things like financial stressors, education, and relationships. So the first thing we do with sickle cell disease, which we use for acute complications, like we talked about in this case, is transfusion therapy. This is where you give somebody else's blood. So I take blood from a donor and I transfuse a sickle cell person to correct anemia, to help improve acute chest syndrome, to treat multi-organ failure, but we do not give blood to treat uncomplicated acute pain crisis. This woman was hypoxic. She was in respiratory distress. She probably had a little bit of acute chest syndrome, and she was septic, so we gave her a transfusion. Unfortunately, she suffered from one of the complications of transfusion, which is at the bottom of the slide, delayed hemolytic transfusion reaction from alloimmunization. Giving blood repeatedly can lead to infection risk. I know when I was in medical school, people would get HIV from transfusions because the system was not that great. And I would love to hear from my colleagues in Abuja, what is the blood supply like in Nigeria right now with regards to transfusing sickle cell patients? Iron overload happens after 10 to 20 bags of blood, and you have to chelate, but again, you have access to this chelation therapy. And of course, alloimmunization, as the doctor mentioned today, is when you provide somebody with blood that is not exactly perfectly matched to their blood. On the minor antigen level, they will develop an antibody, and the next time they get exposed to blood, they end up with hemolysis. So there's several ways of giving blood. You can give a simple transfusion, or you can do what they call an exchange transfusion. This is like a dialysis machine, but instead of using plasma or dialysate, you use blood, and you take away their sickle cell blood and replace it with non-sickle cell blood. So in a simple transfusion, I'm giving you more blood to raise your hemoglobin. In an exchange transfusion, I'm changing out the quality of your blood to reduce the amount of sickle cells and replace with non-sickle cell hemoglobin. And I may not change your hemoglobin total level or your PCV. So it's the proportion of cells that are sickle positive that I'm taking out to replace with hemoglobin A positive blood. in the exchange transfusion. This is a slide that talks about the antibody profiles of most African Americans and how it's different from that of Caucasians. I am not aware that we have this data for the African context, but you can imagine being ethnically African American, you will be very different in your blood profile on the minor antigen level compared to Caucasians. But this is why blood typing should go beyond A, B, and O and go to the minor antigen level. The most common ones to look at is the C, E, and the KEL antibodies. So my colleague really talked about them. I'm not going to go into a whole lot of detail. But when you have immune incompatibility between the recipient and the donor of red blood cells, you can have a reaction. It can happen within an hour or within a couple of hours on the acute setting. And this is usually when you have a major blood group incompatibility because somebody mislabeled the bag and they mistook AB for B, or they mistook O for something else. You can also have it as an acute reaction to minor blood group incompatibility. And typically you get alloimmunized during pregnancy or with prior transfusions. In acute transfusion reactions, the hemolysis is very severe and very swift, and it can happen either in the blood vessel or extravascularly. The delayed reactions happen within 1 to 2 weeks typically, but can extend to as long as 4 weeks. But we have seen within 24 hours up to 28 days. And this patient had hers within 48 to 72 hours. And this happens when you have persistent or anamnestic reactivation of an antibody that was quiet because of re-exposure to blood. Infections can also trigger hemolysis. We see in COVID-19 infection, we see with malaria and with different viruses and also different bacteria that you can trigger hemolysis and they can have a hemolytic transfusion reaction. So when you have a positive Coombs test within 24 hours to 28 days after a transfusion, you call that a delayed hemolytic transfusion reaction. And you really want to identify the red cell antibody because they will probably need to be transfused later on. And you need to be able to know what type of blood to provide to them. Now, in a resource-poor country, how do you manage this, nuance? How do you test for a minor antigen when you don't have the money and you may not have the expertise available to you right at the time? But what you see in the lab, you have a drop in hemoglobin, a gradual rise in your reticulocyte count, spherocytes, jaundice, low-grade fever, elevated LDH and Billy, signs of hemolysis, a drop in haptoglobin, and a drop in your fibrinogen, along with spherocytes. I mentioned that. The patient will present with back pain, flank pain, fever, chills or rigors, low blood pressure, signs of disseminated intravascular dissemination of DIC, hematuria or hemoglobinuria, and progressive renal compromise. In many sickle cell patients, they may develop acute chest syndrome from all of this and also multi-organ failure. And remember that in DIC, they can bleed and they can clot. And the team was very astute in putting the patients on warfarin because the risk of bleeding and clotting had to be balanced. With the leg swelling, you're going to think about a blood clot. So you're going to watch her for bleeding in terms of hemoglobinuria. My colleague went over this. I'm not going to go into a whole lot of detail, but to treat a delayed transfusion reaction, you want to avoid giving blood as much as possible and provide supportive care. Like he mentioned, with the erythropoietin, analgesia, very gentle hydration, and then prophylactic anticoagulation. And if available, we've used things like IVIG, rituximab, or eculizumab. These are very expensive treatments, and their benefits is not perfect. And so you have to kind of balance out treating with these new drugs versus just supportive care if you have no resources. I'm just going to skip over that. And I will share these slides for the team as resources. So how do we treat sickle cell disease? Since 1997, hydroxyurea has been available as a way to treat sickle cell disease, and it comes as a capsule or a swirlable tablet. It was FDA approved in 1998 and is indicated for sickle cell SS and S-beta-0 thalassemia over the age of 9 months old for recurrent pain, acute chest, low hemoglobin, and pulmonary hypertension. And what happens is it triggers your bone marrow to make fetal hemoglobin, which are red blood cells that are very robust and they carry oxygen very well. They don't sickle, and they live a lot longer than 2 to 3 weeks. And the slide here shows one patient on the top panel, A to C, had a response of 25% fetal hemoglobin, D to F had a 15% fetal hemoglobin response from a 1% fetal hemoglobin response. The study that was done called the hydroxyurea multicenter study showed a 50% drop in pain crisis, admissions, transfusions, and infection in sickle cell patients who received hydroxyurea compared to those who did not receive hydroxyurea. And over 10 years, the lifespan, the mortality rate for sickle cell disease on hydroxyurea was 10%, not on hydroxyurea was 90%. So 90% of people who were not on hydroxyurea followed for 10 years had passed away, and 10% only had passed away who were on hydroxyurea for 10 years. Every medicine has complications. The biggest one we think about is the myelosuppression, so the blood counts have to be monitored. But there is data now in sickle cell disease in Africa where you can give a fixed dose and you require a lot less blood test monitoring, so it's cheaper to administer. You can reduce your sperm count. So we say if you want to make a baby, go off of it, make the baby, then go back on it. You cannot use it when you're pregnant. And it takes 3 to 6 months for maximum benefit. But hydroxyurea is extremely effective in sickle cell disease. It is probably the most effective medicine we have to date with data for sickle cell disease. And unfortunately, only 20% of people who should be on hydroxyurea are on hydroxyurea. And I love us to talk about the reasons why people refuse or don't use hydroxyurea in sub-Saharan Africa. Andari was approved in 2017. It's an amino acid protein. It's in a powder form. You put it in water, you shake it up, and you drink it twice a day. It works by reducing oxidant damage to red blood cells and reduces acute sickle cell complications. It reduces the annual rates of pain from 3 times a year to 2 times a year. The other thing we learned is that it drops acute chest syndrome risk by 67%, which I think is a very powerful reason for somebody on Andari. It's taken twice a day. It has barely any side effects except for constipation and maybe a little bit of nausea and belly pain, and it requires no monitoring. But in a country like Nigeria, it is extremely heat sensitive. So it should not be exposed to heat because that will denature the protein. So this is a limitation of using Andari in a tropical country. The other thing is that it's quite expensive. I think the average cost per month is $15,000 US. The same year, we got Adakveo, which is a monoclonal antibody to reduce the frequency of VOC and to delay time to hospitalization and the number of hospitalizations in sickle cell patients who take Adakveo. It is an IV infusion, a humanized monoclonal antibody against P-selectin. P-selectin is one of the factors that helps stickiness of the blood cells to each other and to the blood vessel lining. And Adakveo was able to reduce the median rates of VOCs by 45%, and the analyzed days in the hospital by 42%. A little bit below hydroxyurea, but really quite impressive. And it's given by a short 30-minute IV infusion every single month after a 2-week bolus. It can cause backache and myalgia, but we have very low rates of infusion-related reactions. The problem, again, is that it's quite expensive. It's $150,000 a year to support Adakveo, and we need to figure out a way to make these things more available in resource-poor countries. The last drug that we have right now was also approved in 2019, along with Adakveo. It's called Oxbryta. It's the first of its kind that inhibits sickle cell hemoglobin S polymerization, and it prevents the cell from going from round to sickle as it comes out of the bone marrow, and so it reduces hemolysis and will improve your anemia. So we found that it will reduce hemolysis and increase anemia in about 51% of the people on the study. They had a 1 or more gram of hemoglobin rise over the 1-year study duration. Sorry, over the 24 weeks and all the way down to 3 years of study intervention. There's a risk of allergic reactions, not that common, but it's a possibility. There's some drug-drug interactions, and it can cause some GI discomfort, which is the main reason why people stop the medication. But the trick is start with 1 pill and then build up to 3 pills, which is a full dose over time. In Nigeria, in the US, in Europe, we know that allogeneic stem cell transplantation is the way to cure sickle cell disease. It's been around since the mid-80s to early 90s, and it requires a matched brother, sister, or family member to get the best results. The best results happen when you're under the age of 16, but we have done transplants in people who are in their 50s, and they've done very well. The problem with stem cell transplant is that the earlier you do it, the more effective it is to prevent long-term damage. If you already have kidney failure, it's not going to reverse sickle cell damage that has already happened. And is it available to everybody? When I was at Emory, we had the most sickle cell transplants in the United States, and about half of those patients were Africans of African descent who came from Africa, came from Europe to get their bone marrow transplant. In children, 93% overall survival, amazing. In adults, 81%. There's a 5% mortality rate and a 5% rate of something really bad like GVHD or some other complication. And in my mind, anybody with sickle cell disease should get a transplant if they have the access to it, because that's the one way to cure the disease. However, there are guidelines as to who will qualify for a stem cell transplant. It is extremely expensive, about a quarter to $500,000 to go through the whole process. And it's not a walk in the park. Plus, you have to have a brother or a sister who's a match to be able to proceed to stem cell transplantation. So now in the past 5 years, 10 years, there's this new stuff called gene therapy. And gene therapy is a way to cure your disease without needing somebody else's bone marrow stem cells, but using your own stem cells, having it fixed in the lab, given back to you, and we wait to see if you recover. There are currently 12 trials looking at gene therapy in sickle cell disease. And I was on a panel yesterday with 4 people who had been cured of sickle cell disease using gene therapy, 4 different protocols. The CRISPR-Cas9, the gene addition, the gene editing protocol. It's really like the highest and the brightest research about sickle cell disease curative therapy that's out there. So what they do, they take your stem cells from your body, they put it in a tube, they work on snipping out the defective gene or adding something to kind of fix the way the gene translates to red blood cell production. They grow that and then they give it back to you, and then they wait to see if it takes into your bone marrow. And so this is the way of the future. Is it available right now for people? Not yet, but maybe in the next 20, 30 years, we'll have it to where it'll be available to more people. The challenge is to get enough cells to take on the new vector, take on the new change, and live in your stem cells in perpetuity to keep making those corrected hemoglobin molecules. So that's the main issue. And then of course, the risk of downstream having genetic imbalance that will lead to maybe leukemia or other defects is something we're still working on right now. Sickle cell disease is not just a physical disease, it's an emotional disease. Do not forget that. This lady who we just saw on the case, we need to find out what is the reason why she has pulled away from healthcare when she's quite sick. We need to figure out how to bring her back into healthcare to help her live a longer and healthier life. So the challenge of sickle cell disease in Africa, this is my second to last or third to last slide. Most of the babies are going to die before they turn 5. We have an extremely high infant mortality. We have a huge burden of treating this sickle cell disease in countries, but we don't have the resources or the structure in place to make these programs comprehensive and universally available. Newborn screening pilots have been done since I was in medical school in Africa. And only in maybe Ghana and Benin have they been able to do this to a degree where it even dares to be mentioned in the international spheres. We are still in infancy in Nigeria, but there's a lot of work that's being done with partners to overcome this. But it's quite complicated. If you find these babies, do we have the resources to treat them, not just up until age 5, but beyond age 5, because they're going to survive the acute problems, but live to have the chronic issues that sickle cell patients develop as they get older. We learned that lesson in the US. What the US did to help with newborn screening was implement penicillin prophylaxis, education, and genetic counseling. And this right there was the main thing that led to improvement in the under 5 mortality. I know that the Society of Hematology in the US has launched an initiative in both Nigeria and Ghana, and they're moving into these other countries to help work on ways to provide newborn screening in a universal country-driven format. But it does require a lot of partners. You cannot do this by yourself. In a country like Nigeria, we got to make sure that we have the political will to support implementing a structured process that is sustainable over time. Who will pay for this? Do we have the skills in terms of manpower? I think we do. Do we have the political will? I think that's a work in progress. So the way forward for Nigeria has to be a combination of scientific evidence, social infrastructure, political will, and public policy. We have the scientists. You guys are amazingly trained, well aware of what needs to happen. You have the skills. What we need to work on is the political will, social infrastructure, and the public policy, and the community engagement to make sure that we can figure out a way to make newborn screening in Nigeria a thing of not an issue to be dealt with, and then move towards dealing with adults and geriatric sickle cell disease in the future. I'm going to pause here, stop sharing my slides, and see if we have time for a robust conversation.
Thank you very much, Dr. Sunkwo, for that very, very comprehensive lecture that covers a whole range of subjects in sickle cell disease, and also for keeping to the time. It is really a remarkable presentation. I cannot sufficiently tell you how happy I am to hear you give all of these details, particularly the part that dealt with newborn screening. Well, that is a subject for another time. For now, the lecture is open for questions, and I'm going to, if you have a question, please let us know. I don't have a way of knowing who raised their hands, but I'm sure that my secretariat, Letitia, will know and will let me know who we should be calling. In the meantime, I'd like to ask a few questions concerning the case presentation before we move on. The case presentation was of a young woman who presented with left shoulder and left hip pain. I did not hear anything about that pain after the presentation of the symptoms. Did they do X-rays? Because patients, a 31-year-old woman, may very well have avascular necrosis of those joints. That would be the first thing that I will worry about. The second thing that I will worry about is the fact that the patient is breathing 27 times a minute. So the patient is tachypnic, and at the same time, the patient is relatively hypoxic with oxygen saturations of 90%. Did they consider the possibility of an acute chest syndrome, which is what I would be worrying about, the 31-year-old woman who comes in tachypnic. Usually when your tachypnea is from fever, your oxygen saturations are normal. But in this patient, the oxygen saturation was not normal, in my opinion. The third thing is the intravascular hemolysis, which was described. Usually we avoid it if we do a good cross-matching. We avoid intravascular hemolysis. You don't even need to know what kind of antigens the patient has. Cross-matching will tell you that the blood is not going to be compatible. I don't know how much cross-matching we did. Those are my three comments, but I will leave the rest to the audience to ask questions. I have Dr. Albert Ayeni, who has raised his hands, and I will recognize Albert to ask his question.
Good morning, good afternoon, good evening, wherever we may be located. I'm so excited to be part of this discussion today. I just retired recently from Rutgers, and the issue of sickle cell is something that was central to our activities way back in 2020, from 2002 to I think about 2012. We had a conference here at Rutgers, 2001, where the then Minister of Science and Technology, accompanied by so many other prominent scientists, came to Rutgers for a program on biotechnology. To cut the whole story short, we had an eminent pharmacologist here, Dr. Ramesh Pandey, who was part of that conference. And he became so much interested in the issue of sickle cell. At that conference, the minister got to know Professor Pandey. And Dr. Pandey has a lot of experience in natural products chemistry and how to manage some of these diseases. And in short, we were in Nigeria together with Dr. Pandey, who became very much involved in developing a product that was actually discovered by one eminent pastor. I can't remember his name now, for managing sickle cell locally. It involved a few natural products that all are available in Nigeria. And they put that mixture together. And the claim was that that was probably the most effective treatment for sickle cell disease. And by 2006, let me fast track the story. The then president of Nigeria, General Olusegun Obasanjo, was invited to launch a product that was spearheaded by Dr. Pandey. That product is Nicosan. Probably Dr. Osunkwo is familiar with this product. Nicosan was known at that time to be the best treatment for sickle cell. And Dr. Pandey established a factory in Nigeria to produce this Nicosan. And he succeeded in actually placing this thing on the Nigerian market. And that product was available for a period of 2 or 3 years, but so many issues came up that made the product disappear from the market. My question is to Dr. Osunkwo and any other person in the team, whether anyone knew anything about Nicosan in Nigeria. The story that we have is that it was the most effective treatment for sickle cell.
Dr. Yeni, I will have to stop you because we need to go.
Yes.
Please, for all other questions, please try to be brief. All I can tell you is this.
Yes.
Dr. Pandey was invited by AMPA to AMPA meetings to make his presentation.
Yes.
Nicosan was tried and clinically tried in various centers and was found to be totally ineffective. And that is how Nicosan died a natural death. Okay. So I don't want to belabor the issue. Okay. Dr. Osunkwo, probably, if you have a comment, please make it.
No, I don't. I was going to say that there's no evidence in randomized clinical trials. So you go by the evidence. You have to be careful not to go by sentiment and by emotion. Glutamine and DARI is an amino acid, and the only reason why it got approved was they were able to show in a phase 3 study that it had an effect. It was a modest effect, but they showed that. Nicosan was not able to be demonstrated like that, and that's why it died. It didn't get support because you have to show me benefits that outweighs the risk. And so that's usually how drugs get approved.
Thank you very much. We have Sickle Jackson. I don't know where Dr. Jackson is from.
Okay.
Question.
My name is Sickle Jackson. I'm presently in Philadelphia. A recent graduate. I just graduated with a PhD in health economics, health services research. I finished from the University of Calabar and had my master's at the London School of Hygiene and Tropical Medicine and PhD at the University of Texas Health Science Center at Houston. And Dr. Osunkwo, this is a very important topic to me because my dissertation was on a cost effectiveness analysis comparing treatment options in the prevention of acute painful crisis in pediatric in sickle cell patients. And I've sent the papers out for publication, and presently they are under peer review. I wish I had met you earlier, probably would have been on my committee. And after now, I'm going to send you an email to get to know you more because I see this, the dream of me. I want to become who you are right now. So, okay. I want to ask, is there any room for a combination therapy treatment options, like maybe combining hydroxyurea and L-glutamine or voxelotor, crizanlizumab. In my study, I found out that with a willingness to pay of, let's say, about $50,000 US, L-glutamine was more cost-effective, though crizanlizumab and voxelotor provided more benefits, but it depends on the willingness to pay. So is there any room for a combination therapy? Thank you for making this great presentation and looking forward to seeing you someday.
You're welcome, Dr. Jackson. So that's a wonderful question because it's the reality we face right now. No one drug is going to be universally effective in fixing all the pathophysiology of sickle cell disease. Remember, I showed you it's the hemolysis, it's the vaso-occlusion, it's the thromboembolism, it's the vasculopathy. So we believe that sickle cell treatment of the future is going to be like cancer treatment of the current, multimodal therapy using multiple agents. And so yes, there is a place for multi-drug combination therapy in sickle cell disease. Actually, right now, the recommendations that we put everybody on Andari, that's a universally available drug for any sickle cell genotype. And then based on your genotype, you can do hydroxyurea. Based on your hemoglobin, you can do voxelotor, and your pain story, you can do crizanlizumab. So absolutely yes, combination therapy is going to be the most effective way of treating sickle cell disease because you can have a lot of hemolysis and a lot of pain, and these drugs work on different pathways and have different efficacy. So to get the best outcome for the patient, you're going to have to target different pathways.
Prof,
thank you.
Dr. Soto Omogui, Prof. Dr. Soto Omogui is a pain specialist who was actually supposed to be part of this talk, but he went AWOL on me. So he might have some comments on pain management of sickle cell patients because he sees a lot of them. By the way, he was a former chair of the Southern California AMPA chapter. So Sota, you want to say a few words before the prof comes in?
Yeah, thank you very much. First of all, as we all learned growing up, prevention is better than cure. If you look at the pathophysiology of sickle cell, right from the discovery of sickle cell as the first molecular disease discovered by Linus Pauling in 1949, when another hematologist noticed that in patients with sickle cell, there was more sickling in venous blood than arterial blood. And from that point on, the pathology of sickle cell has been known that is essentially oxygen is a common factor in the sickling process. And there have been multiple studies on this whereby the initial polymerization of hemoglobin, which is occurs in a low oxygen environment. And from that, the cascade of endothelial damage, inflammation occurs. And the process of sickling occurs reversibly for the vast majority of time, whereby when the hemoglobin gets to the lungs after leaving the venous system, the polymerization is reversed. And this occurs repeatedly throughout the whole process. And multiple studies have shown that polymerization is directly related to the partial pressure of oxygen. So before we go even into the pain management of sickle cell, in my clinical experience, you are able to prevent 90% of sickle cell crisis by the use of a gas, oxygen. And how? It's also been noticed that in sickle cell patients, you have nocturnal desaturation of oxygen, which means when they sleep, due to the shallow respiratory rate, oxygen saturation is decreased. And interestingly, the vast majority of crises in sickle cell occurs at night when patients are waking up from sleep. So the very simple thing of providing oxygen by an oxygen cylinder or an oxygen concentrator to patients who feel tired, who are stressed, who have any predisposing factors to a crisis, and delivering that oxygen to them at night by simple nasal cannula, 1.5 to 2 liters per minute, can stop the vast majority of crises from even occurring. And when you look at oxygen, and you look at the newer drugs that we have now in the United States, including voxelotor, what does voxelotor do? It shifts the hemoglobin oxygen dissociation curve to the left and allows the cells to retain oxygen during their transit through the capillaries. Because that's where the cells get sickled, when they're transiting in the capillaries and they've given up their oxygen, and that's when the hemoglobin polymerizes. So what voxelotor does is that it allows, and this is just a transient transit time, about less than a second, allows the hemoglobin to retain the oxygen during that transit so it does not polymerize. So the first thing in prevention is oxygen. And it's been noticed right from 1949, but somehow it's been essentially overlooked. Then the other thing, when you have a crisis, and I was listening to this case, is the management of the pain. The use of pentazocine is really not very desirable. It's an agonist-antagonist. So it has a ceiling effect on analgesia. You do require pure mu agonists like morphine, Dilaudid, even Demerol, in terms of getting pain control. And pain control is critical because pain causes hypoventilation, giving you more atelectasis, giving you more hypoxia, increasing the sickling of the cells, and creating a vicious cycle. So it's very important to control the pain. So I think you need to think more of using more mu opioid agonists. Now, not just narcotics, because sickle cell is also has an inflammatory, significant inflammatory component. You should always combine your opioid with an NSAID, like parenteral diclofenac. Here in the US, we use parenteral ketorolac, Toradol. So, and together with oxygen in terms of maintaining the best saturation to prevent the cells. Now, also, one thing in terms of the treatment of sickle cell crisis is that treatment within the first 15 minutes of a crisis can abort a crisis. And what's that treatment? Oxygen, and having the patient being able to administer the initial doses of an opioid or an anti-inflammatory that they have used before in the hospital and they have tolerated. And this can be done using telehealth, whereby the patient can be monitored by video, and there can be remote monitoring of this oxygen saturation with the pulse ox and the blood pressure, and the patient's family has available intranasal naloxone if they need to reverse the effect of the opioid. And you can have home care nurses go and visit the patient. The reason is that the longer the pain occurs, the greater the cascade, the inflammatory cascade, the sickling cascade, and the greater the pain. Sickle cell pain crisis is a misnomer. What is happening is not just pain, it's multi-organ damage. And so calling the sickle cell pain crisis like calling a myocardial ischemia a heart pain crisis. There's no difference. And sickle cell has more damage than even a myocardial ischemia because every single organ in the body can be damaged. So it's very important that we begin to look at sickle cell, not just as a crisis, but as a multi-organ damage and address it. Prevention, early treatment, adequate opioid and anti-inflammatory treatment. Now, this young lady, obviously, trying to control her pain, was taking a lot of NSAIDs, which resulted in peptic ulcer disease and inadequate pain control. So I think that these are things that when you're looking at the management of sickle cell crisis, you need to take a look at that. Now, if you don't have a pure mu opioid, you can also use ketamine, low dose ketamine. In my clinic, I use ketamine on a daily basis, and low dose, not anesthetic dosing. When I say low dose, I'm using 5 milligrams of ketamine, which in a ketamine vial, which is 50 milligrams per ml, I'm using 0.1 ml. And when you use ketamine, it can low dose ketamine, you don't experience the hallucinogenic effects, and you significantly potentiate the use of any other opioid you're using, whereby you'll be able to use decreased doses of the opioid, combined with an anti-inflammatory. So that's my what I need to say at this time.
Thank you very much, Dr. Sota Omoigwe. We appreciate your contributions. I don't know if Dr. Sunkwo has a comment or two to make about this presentation of Dr. Omoigwe. If not, then we'll move on.
That was very, very helpful. The only thing I want to comment on is that implementing exogenous oxygen to everybody has some pragmatic challenges in terms of access. That's the first thing. Second thing is you have to be careful not to suppress red blood cell production in somebody who's hemolyzing and is anemic, because what it does, it potentiates the need for transfusions and it becomes a vicious cycle. There were, in the 70s and in the 80s, there was a lot of talk about oxygen for all, and that was where we began to see the issue of transfusion rising, and so that had to be balanced based, with the whole oxygenation. But you're right, sickle cell is a disease of oxygen deficiency on the hemoglobin molecule level and the red cell level. And you're absolutely correct. Preventing early is important. Newborn screening, genetic counseling. And we didn't touch on how to treat pain today because the goal was to talk about the delayed transfusion reaction. But I would love to hear from the Abuja team. What are their resource constraints around pain medications? When I was in medical school, I don't think I ever gave morphine in the 6 years I was at UNN to anybody. We used Novalgine, we used paracetamol, and we used some other medicines, but not, I never gave morphine. It just wasn't available. So I don't know what things are like now in our country. It would be nice to hear from the Abuja team what their thoughts are about that.
Well, Dr. Aluya has his hand up, but I will really want to hear from this iPhone UNN. I don't know who has the iPhone UNN thing. I want to hear from somebody in Nigeria who has the iPhone UNN. Please, if you are hearing me, you please say something because you have your hand up. Well, iPhone UNN is
iPhone UNN?
Yes. Okay.
Okay. I think his hands are down now.
Down. All right, fine. Then let's hear from Nelson Aluya.
Well, thank you so much. Thank you so much, Frank. I must thank everybody who's been here, just waiting and hearing this amazing and stellar presentation. And again, I thank AMPA and the leadership of AMPA to putting this together in line with the great work that the FMC, Abuja have been doing, the group that have been putting this together consistently for the last couple of months. I must say thank you so much, Dr. Sunkwo, for your great presentation. It's amazing, and it's incredible to hear one of our champions speak. And I call you a champion. And I say that because and I'll say it this way, that you must create the platform for your masquerades to dance. Because until you create that platform, you never know how well your masquerade can dance. And this is the platform to know that our masquerades, who are champions amongst us, can perform and can dance on the international space. And that's one of the reasons why we created this. And not just that, to also give, that seamless collaborative network between those in the diaspora and those back home. And also to give our young upcoming geniuses who are just graduating, residents or interns, or I don't know what they call them now in Nigeria, the platform to speak on international space as well, so that we can hear what they do, how well they're doing it, and again, can collaborate with what we can offer at this time. Now, another reason why we're doing this is to also find that platform where our voices can come together and advocate for issues that really concern us. It's a shame and a disgrace that this is a Black man's disease, pretty much. But that was first delineated. In fact, sickle cell was the first disease that the genetic component was delineated. And it was actually first done in a dentist who came from the Caribbean. The poor guy was sickling all the time. They didn't know what was wrong until some brilliant guy went ahead and did it. Unfortunately, he did his job well, graduated dentistry, and went back to the Caribbean and died subsequently. Now, why is that? Why am I saying this? Dr. Zukwan said 50 to 90% of people in sickle cell with sickle cell die before the age of 5. And that's a whole lot of brilliance in the continent that we're losing. And we all know that we've had a whole lot of young, bright men who are sickle cell patients who've done stellar work across the globe. And they're exceptionally bright. Why do we continue to lose those children? That's one of the reasons why we're having this, so that we can connect and put our network together and all our resources. And when I say that resources all the time, money, and your intellect. If you don't have the time, you have the money. If you don't have the money, you have the time. If you don't have the time or the money, you have the intellect. Let's put all of that together so that, for instance, a typical case, that newborn screening, like they do here, should be done in Nigeria. I mean, you mentioned that, was it Togo or one other smaller West African country are the ones who are doing newborn screening. The giant of Africa does not have one. And this is where we can begin to stand up and begin to speak, so that we will put our pressure and our thumbs on the heads of those who can get this done, period. Because then we'll begin to save more lives. And my doctor said prevention is cure. We prevent it by having those children being born in the first place, so that they don't have to go through what they're going through. And we don't have to count all this number of deaths that we're counting. Now, outside of that, we know now that two components, nitric oxide, it's a big issue in managing diseases across the globe. And it's easy. Sometimes, you can get nitric oxide from even food. The very potent glycerin, amino acid can give you a whole lot of it. How much research is being done so that we can identify foods in our area that can help us produce nitric oxide so that we can help manage the diseases as we see. Now, outside of that, Dr. Sukwa, my question is this to you. What is your thought on CRISPR? Because when CRISPR first came out, the initial thing they wanted to do was to use sickle cell as a first study for CRISPR. And I said, these people, they've come again. Why all these years, nothing has been done on sickle cell since for the last 50 years when hydroxyurea came out, until recently when we had the Veloxator and all that. Nothing's been done. And we in Africa, we did nothing. Now they're trying to use CRISPR and using sickle cell as the first template. They're still working on it. Again, what's your thoughts? And before I conclude, please let us combine our resources together, time, money, and intellect, so that we can begin to advocate for our people back home save lives, save livelihoods. Thank you.
You're welcome. Thank you so much, Dr. Aluya. So it's a very simple thing. So CRISPR is a precise gene correction tool, right? And sickle cell genetic defect is one amino acid. So it's like, you know, go for the easy disease, right? It's the simplest mutation. It's the easiest one to target. And that's why they want sickle cell disease to be their prototype. I actually was on a panel yesterday and the day before yesterday, and one of the patients got the CRISPR gene therapy and is cured. One got the Bluebird Bio gene correction, where they took out a piece of gene and put another gene. And there's 2 other protocols. So all of them have potential. All of them have potential. The question is, we need enough time to look at it in clinical trials to see if it can be widely used in multiple domains. You know, I have this come see, come start with why are they doing sickle cell disease first? We've been waiting forever for something. And so maybe we need to go first, because if we don't, we may never ever go. It may be another 100 years before they think about using CRISPR and sickle cell disease. So, you know, I look at it from both sides. You know, when you think about the COVID-19 vaccine, people are like, oh, why are they asking the Black people to get vaccinated? Most people who are going to get vaccinated are not Black. And the people who are dying are the Black people. So sickle cell patients are the ones who are dying from sickle cell disease, right? And if there's a technology that will cure sickle cell disease, we need to be first in line to get that technology. And we need to kind of get past the, are they going to use me as a guinea pig? We're all going to be used as guinea pigs at some point. So that's not the big issue. So there is potential. I do think that encouraging our people to participate in research is going to make the studies happen faster. Part of the issue with why it's taking so long for drugs to come is that we're so nervous and scared about participating that you fund the study and you can't finish the study because you don't have enough patients with sickle cell disease, right? So it's like a double-edged sword. When blood pressure was first treated back in the day, the medicines were tested in only white people and they didn't work for Black people, right? Because Black people didn't do clinical trials. The same story is happening in sickle cell disease. We have to educate our patients on how to learn about studies, how to detect which ones are good, which ones are not good. We need to learn about them and we need to advocate for access for our patients. So that's kind of my take. I think there's potential for CRISPR. It's probably going to be a game changer, but we need to have people participate in those trials.
Well, thank you very much, Dr. Aluya. I think we have exactly 6 minutes to go. I will call on, I think it's Ayahu. Is it Ayahu?
Dr. Awa.
Dr. Awa. All right. Yes, I saw Dr. Awa, but there was someone else who was waiting to talk, and I haven't called him until I think he has gone. All right, Dr. Awa, if you have a short comment, please, can you make it quickly?
Thank you. Thank you. Good evening. I'm Dr. Awa, resident in training at National Hospital, Abuja, Obstetrics and Gynecology Department. My question is to Dr. My question is to Dr. Osumpo. Just one question, please. Is there any, with the peculiarity of hemoglobin SC, is there any peculiarity in their management as per pregnant women? Because we've had, although it's not so frequent that we see them, but when we do, it's like they suffer more complications than hemoglobin SS patients. So is there anything that we can add to their management to improve their outcome? Thank you.
That's a great question. And the biggest thing with this is the hyperviscosity. So the hemoglobin is prone to red cell dehydration, even more than the sickle hemoglobin. They tend to have a higher hemoglobin level. They tend to suffer from hyperviscosity syndrome a lot more than hemoglobin SS. So when they get sick, and they have not been used to being sick, but they get sick 20 years, 30 years down the line. Unlike SS, they get sick when they're younger. So think about bone infarct, acute chest syndrome, spleen sequestration, retinopathy, and avascular necrosis. Those are the commonest things in SC. And when they're pregnant, you want to make sure you prophylax them against blood clots, or you watch for, when they're in labor, watch for blood clot formation. So that's a big thing with SC. They tend to get a DVT or pulmonary emboli right after delivery or in the peripartum period. But it's important to make sure that you watch for hyperviscosity complications. So the eye, they get the blockage of the vessels in the eye, joints damage, spleen gets enlarged, and they do suffer from chronic pain, which is why I talked about SC is not mild sickle cell disease. because it can have the same type of profound organ damage that you see with SS. It just happens 20, 30 years down the line.
Thank you very much. There is a Dr. Elizabeth Williams who would like to ask a question. Please make it brief. I have 3 minutes to go. Elizabeth Williams.
Well, not Elizabeth, Ahida.
Oh, Ahida Williams.
A retired medical practitioner. I just have a story to tell about 58-year-old man.
Can you tell it short? Can you make it short?
Hello, non-sickler. Hello. 58-year-old man, non-sickler, had hip replacement surgery. No problem. Before that, was transfused with pack cells. It does. Cells 7 pints. No problem. We know they are pints, blood transfusion. The pints are not for malaria because it's endemic. He went home within a week. Exactly 2.5 weeks later, was in hospital because his wife said he had rise. Was almost died at home. Was rushed to the hospital just in time. Blood pressure 95. I mean systolic 95. Temperature over 40. Well, they tried to stabilize him. That's considered. But and put him on antibiotics and antibiotics. In 40 hours, nothing was improving. And malaria was changed. 2 days later, still no change. By this time, he was beginning to hyperventilate. Blood was sent for malaria parasitosis, but they just said before the results came out, those were put in. They thought of infection, malaria or bacterial infection. Anyway, he began to hyperventilate, and they kind of didn't know what to do. I won't say, let me put it away, but it got progressively worse. And one night I just thought, look, I think I should move this guy to an ICU center. But fortunately, the hematologist came in just in time, who said, look, I suspect tomorrow morning, that would be Friday morning, we'll send for cities. Maybe he's going to throw a clot. That turned out to be so. But fortunately, Thursday, the night before the city, he was started on anticoagulants, which maybe was a bit late, but we thought all ended well. The city came out, and truly, at the site of the EBT, there were 2 little clots. So he was just saved in the nick of time. So I thank God for that. Now my question is, when do you introduce anticoagulants in SS crisis? I'm sure it's not routine. And we are talking about immunizations today in sickle cell. I don't know about them here because I've been out of practice for a while. Can you tell me the name, please?
Just to address the clot issue, in the US, every admission for sickle cell disease, they start them on prophylactic anticoagulation right off the bat because the risk of clots is extremely high and the risk of repeat clots is extremely higher. They have, I think it's like 4 times more clots first time around than everybody else, and I know 16 times more clots in repeated clots. So the risk of clotting is extremely high. So we put everybody on a prophylactic anticoagulation the minute they come into the hospital. That's the routine here. And even despite that, they still have clots. And so that would be my recommendation. I didn't quite hear the second question about vaccines, but the US has a vaccine protocol that starts at a child. You do your penicillin prophylaxis, pneumonia vaccine against pneumococcal infection, Haemophilus influenza, hepatitis A. I'm trying to think of the other one. Of course, the flu and the COVID vaccine are also recommended.
All right, I think we have exhausted this discussion. There are 2 hands still up, but I don't know what I
Hello.
can say.
Hello. Hello.
He's been raising up his hand since.
I'm sorry. That is what I'm trying to see if I can get Femi Adegbonmire to say something briefly. And I see Dr. Sota Omoigwe's hand is still up, or is that an old hand, Dr. Omoigwe?
No, it's a new hand.
All right, Dr. Adegbonmire.
Dr. Ramesh.
Can you say something?
Good morning, everybody here in the US, and good afternoon there in Nigeria and over the world, wherever this is coming from. Having established that sickle cell is a major disease, and the fact that this rampant in the world, we have 100,000 in America, 4 million in Nigeria, 12 in Africa, 12 million in the world. The question is that with this kind of discussion, is it possible for us to come up with a list of treatment medication that is right there? I know that Nicholson was talked about by Dr. Oyeni before. Do we have an approved, proven medication that is out there that can be recommended or can be established in this forum that can help to alleviate this problem among our people, especially within Africa and the Black American here in the US? Do you have a list?
Ify, that question is for you.
So there's sickle cell guidelines that have been published in the US. The last one was in 2014 by the NSODI, and the most recent ones were by the American Society of Hematology. And the standard of care is hydroxyurea, 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 and then the comprehensive care package, which is take your vitamin D, your folic acid, see your doctor, see for complications, and get educated. In Nigeria, I believe Adegalino and some other providers have put together a more practical approach for the Nigerian context. And if I'm not mistaken, please don't quote me. It includes anti-malarials, penicillin, bendazole every 6 months, and vitamin A every 6 months, and then you just watch for complications. Hydroxyurea is recommended if it's available, but it's not available. In the US, depending on your complication level, we recommend either hydroxyurea and Ngari, crizolizumab, or Mocrelator, but it's a stepwise approach. It's really hard to carry the American thing and put it in Nigeria because the cost is unreasonable. But I would recommend, I think there's a Nigerian sickle cell consortium that we work with them to figure out the context for the Nigerian population. But really, you got to know they have the disease, and then you treat the disease accordingly. You treat the complications, prevent them, educate them, and if they're eligible for hydroxyurea, you put them on hydroxyurea. I think there's a tendency to want the new thing. Hydroxyurea is an old thing, but that's the best we have. So if we're looking for what is the standard, I use it for SC, I use it for SC plus L because there's nothing else out there that we know that is as simple to give and as effective. And if it doesn't work, it doesn't work, but it actually works very well for most of the sickle cell patients that we have. So there's no need to come up with a new treatment that costs $1 million when the basic one that is not as expensive, it has not been used optimally.
Can I just ask, take a supplement of this? Do we have a supplement, or can we seek a supplement instead of prescribed medication?
There's no supplement that has been shown.
Let me intervene at this point. I think Dr. Adegbonmire, AMPA is planning a medical mission to Nigeria in the next few months. That's a major undertaking. And that medical mission, Dr. Abraham Oshimbowale, who is our chief of advocacy, will be doing a lot of advocacy work. I'm giving you this heads up information. You can contact AMPA so that if you are interested, you can liaise with us. I am trying to see if I can drag Dr. Sunkwo to come with us. She is a very busy woman. If I can get her to come with us, she will be available also for the kinds of information and strategies that you are asking. Is that okay with you, Dr. Adegbonmire?
Oh, that's fine. And
Right.
thank you. I won't have the president. I have Dr. Aluya just next to me. So
all right, lovely, lovely. Final comment, make it as brief as possible, will come from Dr. Omoigwe. who made a presentation earlier.
Thank you very much. When I hear all of these requests of supplements that can prevent sickle cell crisis, I want to address the issue of that providing oxygen can suppress the bone marrow. I'm not sure when those studies were published, but we have published studies now that show that nocturnal hypoxemia is related to the frequency of sickle cell crisis. That means hypoxemia at night or at bedtime. And if the patient, and the saturation at night in sickle cell patient goes down to 86%. So when the patient is hypoxic and you're giving them oxygen, you are not going to be depressing the bone marrow. And so it's a very simple prevention that if you provide oxygen at bedtime, not every day, but when there are predisposing factors, you can prevent the crisis. And most crises occur with patients waking up at night. You can get the clinical history of your patients and you can relate, and you will get that relation of them having a crisis, waking up from sleep or at night. You have oxygen, it's much cheaper to provide oxygen than to have a 1, 2, or 3 week hospitalization. So that's what I think all of you should look. There are studies out there. If you go on the internet and you search under my name, you will see the articles I've written. Thank you.
Thank you very much. Finally, I have to bring this to a close. I want to thank AMPA President, Professor Kunseri, Professor Ahmed of Federal Medical Center.
Anyway,
I want to thank Dr. Bioku and Dr. Shimbowale, all of them who put this beautiful session together. And the most thanks go to our lecturer, Dr. Ifeanyi Osunkwo, for giving such an excellent expose of the subject matter itself. This is an ongoing collaborative work, and there are more to come. And the February lecture is already in preparation, and I'm sure that we'll all enjoy it as well. I want to thank all of you and have a beautiful rest of the day. Thank you.
Thank you very much. Our next grand round will be February 25th, and we will be discussing orthopedic management of osteoarthritis and quality of life. Thank you.
Thank you very much. Thank you, everybody. Thank you, the technical team, US, technical team, Nigeria. Bye.
Thank you, Dr. Adebayo, for everything. Thank you very much.
Thank you, sir.
Bye.
Thank you.
Bye, Prof.
Thank you.